Hi, everyone. Welcome to APP QD Clinics. These are curbside consults between the advanced practice provider and the rheumatologist about cases that we co-manage. Today, I'm joined by a longtime colleague and best friend, Leilani Law. So I'm Jack Cush in Dallas, Texas. Leilani,
I'm Leilani Law. I'm from Dallas, Texas.
okay, so the good news is that we've done this a lot, meaning we've worked together since I think it was 1993. So over 30 years, Leilani and I have worked together, and she's taught me a tremendous amount about how to manage patients. And together we've seen some great patients. And what we're going to do is kind of do what we do normally, which is we ask questions about patients we share, we update each other. And then when we get to a head scratcher, we do these curbside consults on what to do. So Leilani recently asked me about a patient that I label this as unweanable polymyalgia rheumatica, question mark. So Leilani, I'm going to sort of summarize what we had talked about, and then I'm going to ask you some questions. So this was a 70-ish year old white guy who was diagnosed by the primary care doctor maybe 8 or 9 years ago. He had shoulder and hip stiffness and pain. I assume his labs were in the PMR range. He also had some peripheral joint symptoms. Because of that, he was started on prednisone and was sent at some point to a rheumatologist, and he stayed on that for a while. The chronology here isn't so important because we're talking about what happened almost 9 years down the road as opposed to what happened in the first 2 years. So anyway, he started on 20. He was weaned down to 10, and when he flared, when they tried to get lower, he was started on methotrexate as a steroid sparing drug. So again, you're still not seeing this patient, right, Leilani?
Yeah. No,
But going forward, they couldn't use methotrexate in him because why?
he's had worsening CKD.
Okay. So so they did try to get him down on all these drugs, and actually the rheumatologist did get him off methotrexate and because of the CKD, but also did get him off prednisone, and he was off of prednisone, off of methotrexate. How long do you think it was, Leilani, that he was off those medicines?
It was about a year.
Okay. So the thinking was I guess he was in remission and that was all good, but then things got worse. He flared with pain, but now it wasn't girdle, shoulder, hip stiffness. It was like peripheral arthritis in his hands, fingers, and knees, and his CRP went up and his right knee got swollen.
Yeah,
So,
it was just the left knee
oh, it was
at
a
that.
left knee. Yeah.
Yeah, and it was mostly just the PIPs.
Mhm.
And the CRP got as high as 99.8 milligram per liter, and the sed rate got as high as 66.
So this is you can see I see where this getting difficult because he's got PMR like labs, but he's got peripheral joints without that girdle stuff going on.
Hmm.
So this is confusing to you, and then you find out what's the story with psoriasis?
I just started kind of going through all the review system just to kind of start all over again, just to make sure we're not missing anything. And I just happened to ask, do you happen to have any rashes? And he said, well, I did get diagnosed with scalp psoriasis by my dermatologist.
Wow. And here he is with PIPs and knees. Were his fingers swollen at all? Did he have other signs of psoriasis?
Just the scalp, nothing in the elbows or belly button crack of his butt. And it's well controlled with just the shampoo. And I didn't see any overt synovitis at the PIPs, but I thought maybe there could be subclinical synovitis.
Mhm.
I'm not able to pick up on palpation. The left knee, I did do the joint aspiration, but the synovial fluid analysis was negative. As far as for inflammatory cell count, there was no crystals. That injection, I did give him an injection and it's helped and it hasn't recurred.
Okay. So that's behaving. The fluid was non-inflammatory by cell count. And but does he still at this point still have an elevated CRP and sed rate?
Well, because he was having quite a bit of pain with his PIPs, and it took a while for the injection to take effect, I put him back on prednisone up to 15. Now he's down to 10. His CRP is down to 5.5 milligram per liter, and the ESR is down to 14. Um, his x-rays of his hands and knees is basically OA changes.
Okay. So the question is this PMR? Is this a new arthropathy, either inflammatory or non-inflammatory, that came on because of his age or whatever? And then he also has monoclonal gammopathy of unknown significance. How many things you're going to have that are going to confuse you as to the etiology, going forward. So again, I would say this guy, when you laid this out to me, this was a clear-cut case of PMR. Um, and he went through all that. He went through a few years. We always tell our patients, you're going to be on prednisone for, 8 months to 2 years. And in fact, they're on steroids for 5 years because either it's hard to get out of steroids. The patient doesn't want to get off. You're not good at weaning off, whatever. But I think he had a PMR era. And now the question is, what era is he in now? Is it a PMR or is it an OA or PSA kind of thing? So, what most concerns you about his management now?
As far as what treatment options besides steroid can I offer him if by chance this is not PMR anymore and is kind of morphed into spondyloarthropathy, or I did test him for rheumatoid factor and CCP, both were negative, but could this be late onset RA? um,
And seronegative, right? Well, again, if
mhm.
he, if, that's going to be, I think, here's my bottom line on this, and I think it's a bit of a cop out, but I think it's smart and pragmatic in that it's a little bit like overlap disease. They got a little bit of systemic sclerosis and some rheumatoid, or they got lupus with rheumatoid features, and we call it lupus. And then we want to know how to treat people who seem to have, you know, that are not from the textbook. And the bottom line is you treat what they got. Meaning, if he has, you know, as you did, a swollen knee, aspirate it, inject it, and then see what happens. Um, if he gets flares when you wean his steroids, it's going to be an inflammatory OA, inflammatory PSA, or it's going to be PMR with peripheral joints with a strange presentation. Just treat what he's got, but and do it always in a least risk adverse manner. I think that's kind of the way to go. I just think it's wise to consider a new diagnosis. And you did imaging, right?
Just the x-rays. I was thinking that the next time I told him to continue to taper the prednisone, 1 milligram every 2 to 4 weeks as tolerated. And then as he flare, I was thinking, and if he still doesn't have overt synovitis, I was considering an ultrasound to see if there's any subclinical synovitis that might get picked up.
Yeah. And also, ultrasound being used as a diagnostic criteria for PMR in the shoulder and if not the hip, that I think is a smart way to go. Let's just go back a little bit to steroids. What do you do with a new PMR? An 82-year-old Caucasian woman comes in and she can't move, and she was good 6 months ago. Now all of a sudden she's got bad stiffness, and you find the sed rate to be 82 and the CRP to be 10 milligrams per deciliter, some crazy number. What's your starting dose of steroids?
If somebody has diabetes, I tend to go 10 to see if that's enough to control the symptoms. If not, if there's no diabetes and it's still not helping significantly, I may try 15.
Yeah. And then the only other caveat I think, and I like that approach. That's and I don't think I think about that often enough, like the comorbidities that are dictating what the dose could be. The other thing is how bad do they need to be great? Are they going to their grandson's wedding, next weekend, or is their job and income based on it? Then I might start at 20, right? Just because
Mm.
I need to get them better and there's no contraindications. But I think your dosing is the same. And then when do you want to start to wean? How many
Um,
months?
we usually in 4 weeks, I like to see them and see how they're doing and repeat their inflammation markers. If they're significantly better and that is also reflected by the lab, I start to wean down after
So,
four
and going
weeks.
slow, obviously, right? 1 milligram at a time if they're at 10,
Mhm.
maybe 2.5 if they're at 15. I used to do start weaning at 8 weeks with people.
Mhm.
I think I've gotten, and I think I'm trying to be intelligent about this. I kind of wait until 3 or 4 months before I take them down from the dose that's working, because I do want to get to that being off the steroids in, 8 to 12 months. And I still think, even though I worry about it, I don't get there often enough. And there's a good video on RheumNow from Richard Conway from Dublin, Ireland, where he talks about basically he changes whatever it's going to be, 5 milligrams, 2.5 milligrams, 1 milligram. He changes by month, and he warns them the first week might be rough, and that's to tell them about the steroid withdrawal. So what happens when you get Leilani to they're at 10 and you can't go below 10 because when you go from 10 to 7.5, they flare. They tell you they always flare, and they self-medicate themselves back up to 15, and you're playing that dose, and you're now worried that the flares aren't flares because the sed rate's normal and the CRP is normal, but it's like steroid withdrawal symptoms. Um, how do you get below 10 when you're dealing with steroid withdrawal?
A lot of just education on how to treat steroid withdrawal symptoms that reassure them that their labs are normal, but we just need to have the body adjust to the slow titration. They can take something as simple as Tylenol arthritis, 2 tablets twice a day. And if not better, we can try other options as well. But I think just reassuring the patients that, hey, your labs are normal, and we just need to wait it out, usually a couple of weeks, and they're able to just take some Tylenol arthritis.
And then I make it really complicated. I think these are all like reassurance and giving them a lifeline, the acetaminophen and the labs being normal, but I still think they're freaking out that they're going off the steroid. And that's when I do that sawtooth thing. I'll say, okay, let's go down 1 milligram to 9 milligrams for one day and 10 milligrams. And you sawtooth 9, 10, 9, 10, 9, 10 for 7 to 10 days and prove to them that you can get to 9 and there's no difference between 9 and 10. And then they stay at 9, and then you repeat it all over again, maybe all the way down to 1. But sometimes it takes that long. So at this point, if you had to bet, we're going to Vegas this weekend, Leilani. What's your bet? What are you putting your chips on? OA, PSA, or PMR that you're going to be managing this man long term?
Given that the high inflammation markers, I think it's not just OA. I mean, definitely by X-ray he has OA, but it's hard to argue it's not inflammatory because of the high ESR and CRP. So it's either psoriatic arthritis or PMR. Could you have both?
You can, but I've never seen it, and I did a literature search on it. It's rare, 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 rare. I think it's a much more reasonable thing to expect that, a 70 or 80-year-old man is allowed to get OA or is allowed to get in, PSA, after he had PMR. But, it is that old dictum that why give them two or three diagnoses when one is going to work, right? You see people come in and they say, I have rheumatoid, gout, lupus, and scleroderma, and they're not going to have all of them. and they just basically been misdiagnosed. But there is one, always one unifying diagnosis, and time is going to be your answer. I think what you said is true. If the inflammatory markers when you're weaning go back up, then you are dealing with an inflammatory process, and then you got to
Mhm.
decide whether you're going to use steroid sparing therapy for PMR or steroid sparing therapy for PSA. So when will you use? I mean, the steroid-sparing therapies for PMR are basically when you can't get off of steroids, but you got to pick a time. You got to pick like what's your date? Is it 8 months, 1 year? Often, most people are going on PMR steroid-sparing are going on it many years into the story, and that's not the right way to do it. So, and obviously, sarilumab, the IL-6 inhibitor, is FDA approved. We've got the great data with upadacitinib. Well, actually, that's for GCA. So that's not actually proof for PMR, but it's going to work there. And there's a lot of data about JAK inhibitors being effective. And there are a few JAK inhibitors that are now doing trials to get approval for PMR. But I would use a JAK inhibitor. The data on methotrexate is very dicey. And yes, you're going to use methotrexate because it's the drug we know. It sometimes works, but most of the studies are equivocal on methotrexate, and other DMARDs definitely not proven to work, like hydroxychloroquine or leflunomide or azathioprine or mycophenolate. I wouldn't go there. I'd go from methotrexate to an IL-6 to maybe a JAK if I got into trouble down the line. And then if this is PSA, you're going to treat it with the many options that you have there. Um,
Mhm.
what's the one last question you might have on this?
Um, would you think advanced imaging can help differentiate what we're dealing with here?
Hmm. So, beyond ultrasound and X-ray, there is data about PMR and certainly the utility of ultrasound and maybe even PET scans, right? But it seems like a whole lot of money to spend on what seems to be a pretty pedestrian problem to manage. I don't think I'm gonna, and you know me, I'm not a big believer in ordering MRIs and RA patients or PSA patients. I don't do that unless it's in a clinical trial because I trust my exam and I trust the labs and I trust what the patient tells me. And we do know that advanced imaging, A, is hard to get, B, expensive, and sometimes is fraught with abnormalities that are not pathogenic, right? I mean, there's all the studies about MRs of the pelvis and SI joint abnormalities that are seen in, hockey players, pregnant women, and people who are janitors, and they have no history of spondylitis. So you got to be, know that there is a limitation even to MR or expensive imaging. So I think with trepidation, I would think about it for a while, and I like to use imaging to help me make up my mind. If I can't make up my mind, then I'll go further on imaging. Maybe that's the wisest thing I can say at this point. Anyway,
Mhm.
um, great case, Leilani. Thanks so much. Thank all of you for tuning in. There'll be more APP clinics, curbside consults. Tune in. Thank you.
Thank you. Bye.